Thank you. Uh, Good morning, respected seniors, dear colleagues. Uh, I think Dr. Soilasको फोन आइरहेछ म एकैछिन sorry for the interruption. There was call from Dr. Silas. So, good morning, respected
Morning.
seniors, dear colleagues. First of all, I would like to welcome you all in this NOA bi-monthly meeting. And before starting our academic session, I would like to thank the scientific committee for providing us the BNB and HRDC to host this program. And today we have 7 free papers and 1 ICL. And Dr. Anshul Raj Bhandari is a young orthopedic surgeon who did his arthroplasty fellowship from Sir Gangaram Hospital, and he's currently working in BNB HRDC. He will be acting as moderator, and I will be acting as host. So as a host, I would like to request all the participants to please remain mute and off your video. And if you have any questions, please put your questions in the chat box. Dr. Anshul will forward those questions to the speakers. And with this, I would like to hand over to Dr. Anshul. Dr. Anshul, please go ahead.
Thank you, Rajtai. Uh, Respected professors, seniors, and my dear colleagues, a very good morning to all. I would like to welcome you all to the NOA bi-monthly CME webinar hosted by BNB HRDC. So as Dr. Raj said, we have 7 free papers and 1 ICL. 8 minutes is the allocated time for the free papers with added 2 minutes of question and answer. So I request all the presenters to stick to their time. Thank you. So without further delay, I would like to start today's bi-monthly CME program. I would request Dr. Sailesh Ranjitkar, Scientific Committee Chairman of Nepal Orthopedic Association, to give a welcome remarks.
Good morning, everyone. I would like to thank everyone on behalf of NOA, NOA Executive Committee, and the President that you've given so much of time this early this morning. This is our first bi-monthly meeting which we are hosting for this group of executive team. We have a good variety of presentations from pediatrics to sports medicine and spine. So I hope you all will enjoy it. I think without much of time to be wasted by me, I would like to hand it over to Anshul to start off and continue with our presentations this morning. Thank you very much.
Thank you, sir.
Anshul, I just want to share one information. I had called from Lokraj. He said maybe I will be joining late. So I think after Vivek's talk, we have to proceed further with another talk.
Amrinder, okay, yeah, sure. Okay, thank you, sir. Thank you, sir. So without further delay, we would like to start today's program. And our first presentation is by Dr. Vivek Maharjan from BNB HRDC Hospital. And he will be talking on miscible injury perilunar dislocation. So Dr. Vivek, you may start sharing your screen.
Thank you, Dai. Is my screen visible?
Yes, Vivek.
Yeah, we can.
It is visible.
Yeah. Good morning, respected professors, seniors, and colleagues. Today, I am going to present on a topic which are one of the most commonly missable injuries that are presented in the emergency department. So starting my presentation with a case of a 30-year male who presented with an alleged history of trauma, fall on the outstretched hand and sustained injury over the wrist. Initially, there was pain and swelling, and he presented to the local doctor. and he was diagnosed as a soft tissue injuries, so managed conservatively. The pain and swelling gradually subside with the time, but did not abolish completely. So he presented to our center for the second opinion. This is his initial X-ray of AP and oblique. In this X-ray, we can see there is scaphoid fracture, and the lunate is moreover triangular in shape, and there is break in the gilulars line. So there is something wrong in the wrist. And if we see in the lateral view, this is distal radius and the lunate. The lunate is in lunate fossa of distal radius. However, the capitate and the rest of the carpus has been dislocated dorsally in relation to lunate. So this was a case of transscaphoid perilunate dislocation. This is another case of a 32-year male with a similar stories. He sustained injury over the wrist and he was managed conservatively by a local doctor saying it was just a soft tissue injuries, wherein the pain did not subside and presented to us. In his X-ray, we can see there is scaphoid fracture and there is a break in the gilulars line. And in the lateral view, we can see the lunate is in lunate fossa. However, the carpus, rest of the carpus has been dislocated dorsally in relation to lunate. So this is also a missed case of transscaphoid perilunate dislocation. In both of the cases, we have advice for surgery, but they don't comply with our advice and lost in follow-up. This is a third case of a 52-year male who presented with an alleged history of fall from scooter and sustained injury over the right wrist. And he presented 2 days after the injury. In his X-ray, we can see there is a um, fracture scaphoid and the lunate is triangular in shape and there is breaking continuity in the gilulars line and there is perilunate dislocation in the lateral view. We advised him for surgery and he complied with us and we first approached from the dorsal side. Here we can see the abrasion on the articular cartilage of capitate and there was also a scaphoid fracture and disruption in lunotriquetral ligament. First of all, we relocate the capitate onto the lunate and fix the scaphoid fracture from the dorsal side. Then from the volar side, we repair the wrist capsule and there was also a lunotriquetral ligament tear. However, there was no repairable lunotriquetral ligament, so we transfixed the lunotriquetral joint with the K-wire. And in the same setting, we also did the carpal tunnel release. This is the immediate post of X-ray where we can see the Herbert screw being used for scaphoid fracture fixation and the 3 K-wires being used for transfixing the lunotriquetral joint, capitolunate, and scapholunate joint. This is the wound status on the third postoperative day on the dorsal and the volar side. So coming to discussion, these perilunate dislocations are high energy injuries with poor functional outcome, which occurs with the wrist in extension with ulnar deviation and intercarpal supination of the wrist. These are commonly missed injuries at the emergency department. In most of the literature, these are missed in every 1 in 4 injuries. So why this high rate of missing these injuries? We miss these injuries not because we need the sophisticated investigation like MRI and CT scan. We miss it because we are not interpreting the conventional X-ray that we order carefully. And if we miss this type of injuries, their functional outcomes are poor. So what we need to look in the X-ray, we need to look the 3 gilulars line. The integrity of gilulars line is needed for the normal X-ray. If there is a break in the gilulars line, there is something wrong in the wrist. Also in the AP view of wrist, we can see the lunate is movable triangular piece of pie, giving the piece of pie sign. and there are also lunocapitate overlap. In the lateral view, distal radius, lunate, and capitate are in linear line. And if there is perilunate dislocation only, the scapholunate angle is more than 70 degree. And with the pure lunate dislocation, the lunate seems to be a teacup being spilled, giving spill teacup sign. If there is only ligamentous injuries, then these are called lesser arc injuries. And if these are associated with the fracture of radius, carpal, carpal bone fracture ulna, then they are called greater arc injuries. The lesser arc injuries progress through the four stages of Mayfield. The stage 1, in which there is scapholunate ligament injury. In stage 2, there is capitolunate ligament injury. Stage 3, lunotracheal injury. And in stage 4, there is dorsal radiocarpal ligament injury, wherein lunate rotate and dislocate either polarly or dorsally, but most of the time polarly. And there is it dislocates into carpal tunnels. So treatment is by the close reduction by Tavernier method. So if the close reduction is successful, then we should wait for a few days and do surgery. And if the close reduction is not successful, then we should do emergent open reduction. So during surgery, we usually fix the fractures, repair the ligaments, and do the carpal tunnel in the same sitting. And these are done with the injuries less than 6 weeks. So we can approach from either polar, dorsal, or combined polar and dorsal side. With the dorsal, it gives the excellent exposure to the proximal carpal row and mid-carpal joints. In this, we can fix the scaphoid fracture and repair scapholunate ligament, do carpal tunnel release, LT repair, capsule repair. So in most of the literature, combined dorsal and polar approach are advocated. Post-operatively, we keep a short arm splint and the thumb spica, and these are converted into cast at 2 weeks, and the duration of casting should be at least 6 weeks. So I want to end my presentation with the conclusion that perilunate dislocation are commonly missed at the initial presentation at emergency department. While the simple conventional X-ray that we order is sufficient for making diagnosis, and if surgery is done within 1 week, then outcome is better. Thank you.
Thank you, Dr. Vivek, for the very nice presentation. And thank you for being on time. So if we have any question, we can take few.
Anshul, there are some questions in the chat box. Maybe you can
Yes,
read it from the chat
yes,
box.
yes, I can see some. So there are a few questions on the chat box. There's one from Dr. Buddhi. Why can't a true lateral X-ray can be done in most occasions, though we order a true lateral X-ray? So I think that's very true.
Um, I think due to the due to the difficult position in pain, I think we are unable to get the lateral view. And also in most of the cases, whenever there is X-rays done at the other sense, most of the time, or some may be reluctant to do again the lateral view. Might this might be the cause that we are unable to get proper lateral view.
And also there's a second question. Is CT scan required with this injury in every case?
I think for making the diagnosis, we don't need a CT scan.
Okay, Dr. Vivek, thank you. So we move to our second presentation. And I would like to request Dr. Amrinder Yadav from BNB HRDC to present his talk on a child with a limp.
Vivek,
Dr. Amrinder.
please stop your stop
Yeah.
your screen.
Yes, sir.
Anshul, am I audible and my screen visible?
Yes, you're audible and
Rajesh,
visible.
Anshul Rajesh,
Azhar.
is it possible to show the face of the presenter?
Sure. Yes.
त्यो भयो भने अलि अलिकति अलि रमाइलो हुन्छ कि
हुन्छ.
है
Sure, sir. Okay. Yes, you may begin, Dr. Amrinder.
Respected everyone, good morning. I am Dr. Amarendra Yadav, second year orthopedic FCPS resident at BNB and HRDC. And today I'll be presenting an interesting case about a child who presented with a limp. So to start with my presentation, we had a 12-year-old overweight male who presented to us with a complaint of left knee pain and limping for 3 months, for which he sought multiple medical attention at other center. However, he has no history of constitutional symptoms and denies any trauma. His developmental milestones were normal and had completed the vaccination. So Anshul Rai?
Yes.
अमरेन्द्र प्लिज राइट क्लिक
Continue.
गरेर नेक्स्ट गर न, त्यस्तो भइरहेको छैन.
Okay, sorry.
Yes.
On examination, we can see that the patient had antalgic gait and he was walking with a limp. However, on examination of the left knee, there was no any obvious finding. There was no localized tenderness or the range of movement was full. So the detailed examination was done, and we can see, as in this pictorial, that there was shortening of the left leg, and on examination there was restricted flexion, abduction and internal rotation of the left hip. And as we can see in this video, that there was additional external rotation of the hip, additional external rotation of the hip when the hip flexion of the hip was carried further. Sorry, my video couldn't be played. And by chemical examination of CBC, ESR, CRP were normal, and X-ray was done, X-ray AP, which showed that in normal when a line is drawn is drawn tangentially from the neck of the humor, it should pass through the area of the head of the humor. However, this is called the Klein's line. However, in the case of slipped head of the capital epiphysis, the line does not pass through the capital epiphysis, and we can even see the widening and irregularity of the physis with the rarefaction in this portion of the physis. And apart from the AP view, other views like lateral view or the frog leg lateral view can be done if the finding is not so obvious in the AP view. Here we can see the similar finding in the lateral, the frog leg lateral view of so the same patient. And MRI was done, and MRI are not advised on the regular basis. However, MRI should be done in the patient who have not so much of obvious finding in normal AP X-ray. And typical presentation of SCFE is that an overweight male with a poorly localized groin, thigh, or the knee pain who is limping and may have history of minor trauma, and usually is within the age group of 11 to 14 or the rapid growth phase of the patient. So these are the typical point of presentation for a patient who present to us with slipped capital femoral epiphysis. So to quantify or to classify whether the slipped capital head is stable or not, Loader has classified it on the basis of ability, whether the patient is able to bear weight with or without clutch, or if they are not able to bear weight with clutches. So if a patient is able to bear weight, it is classified as stable, and if they are not able to bear weight, it is classified as unstable. And it is also useful in prognosticating the risk of osteonecrosis. In case of unstable SCFE, there is the high risk of about 47% of osteonecrosis. Next is the temporal classification. If a patient presents to us with symptoms less than 3 weeks of duration, it is acute. And if the duration is more than 3 weeks, it is considered to be the chronic SCFE. However, whenever there is acute exacerbation on a long-standing symptoms, then acute and chronic case of SCFE is present. Next classification is Southwick sleep angle classification. And in this, the difference between the contralateral limb, the difference of the angle between the contralateral limb is calculated, and the angle is between the femoral epiphysis and diaphysis angle, which I'll be showing in the pictorial. And if the difference is less than 30 degree, it's mild, and if it is more than 50 degree, it is considered to be severe. As you can see in this pictorial, a line is drawn corresponding to the axis of the femoral shaft, and the next line is drawn perpendicular to the base of the capital epiphysis. So the angle between these two are calculated on the both side, and the difference is calculated. Here you can see in this patient, it was 8 degree on the left side and 45 degree on the right. 8 degree on the right side and 45 degree on the left side. So the difference was more than 35. So moderate type of SCFE was present. Similarly, we can see the angle angle can be calculated between the shaft of the femur and the line drawn perpendicular from the base of the capital femoral epiphysis. And in the AP view, normally the angle is about 145 to 150 degree. And in case of SCFE, the angle is decreased as compared to the normal reference value. So whenever the diagnosis of SCFE is made, whether we can do it conservatively or operative management should be done. Mostly the patient should be managed operatively to prevent the further slip. And regarding the entry point of the screw, since we are fixing the slipped epiphysis, not the neck of the femur as in other case of the trauma, so the entry point of the screw should be anteriorly. As you can see in this pictorial, that the entry point of the screw is anterior to the neck, so as to catch the slipped part of the epiphysis. And the entry point should not be made on the lateral point because we are not trying to fix the neck of the femur. This is the difference between the traumatic case and the case of fixation of the SCFE. These are few of intraoperative pictorial, where here we can see that the entry point, this is the anterior part and this is the posterior part. We can see that screw placement is being done on the anterior part, and this is the line of the placement of the screw, and it was confirmed by fluoroscopy and CM. And these are two immediate postoperative pictorial taken after the screw placement. And regarding whether one or the two screws should be placed depends upon the patient condition. Usually one placed center would suffice, and so that addition of the further screw, 2 or 3 screw, will give us more screw related complication. And we try to place one central screw, but the slip was not stable, so the second screw was placed. Regarding the removal of the exceeded, however, the screw should be removed after the patient uh, is skeletally mature, or if there is any screw related complication, then the screw should be removed. Since 20% of the patient have bilateral scaphy, so if patient is asymptomatic on the contralateral side and there is no any symptoms, so the prophylactic fixation of the contralateral hip should be done or should not be done. It depends upon the risk factor of the patient. If the patient present to us earlier than the normal time frame, that is prior to age of 10 years, and if they have open trigeminal cartilage and there is chronic renal insufficiency and the SCFE is related to endocrinopathy, then in these cases the contralateral hip should be prophylactically fixed. Regarding the follow-up, the patient should be follow-up on the SOS basis if they have any symptoms, or they should be followed up 6 monthly with a lateral radiograph until the patient are skeletally mature. So this is my final slide, which showed the algorithm regarding the management of the SCFE. The SCFE can be either stable or unstable, and it can be varus or the valgus SCFE. So whenever the patient present with less than 3 weeks of symptoms, and there is the acute presentation, regarding the reduction, if the patient present to us with less than 24 hours of the symptoms, then we should try reducing. And if a patient has duration more than 24 hours, then reduction should not be tried, because it will lead to further disruption of the blood supply, and in situ pinning should be done without the reduction of the slipped capital head. If the duration is more than 3 weeks and the presentation is chronic, in situ pinning should be done. And if it is associated with any complications such as impingement, chondrolysis, or avascular necrosis, and the related complications should be managed accordingly. So to conclude my presentation, and overweight child in the rapid growing age of 11 to 14 years with poorly localized groin, thigh, or the knee pain with limping. A differential diagnosis of slipped capital femoral epiphysis should be kept in our mind, and the age or the prabhav that any child or adolescents who present with complaint of pain in the knee region must first undergo careful examination of the hip, including radiograph if necessary, before examination of the knee is still true. Thank you.
Thank you, Dr. Amrinder, for an interesting case presentation, a very rare case in our population. And the incidence of this kind of missed SCFE during primary care visit has been reported up to about 48%. So one should always have a high index of suspicion. So we can take a few questions. We have one question in our chat box. How do you evaluate Southwick slip angle if there is a bilateral slip is present?
If bilateral slip is present and the abnormality is on the both side, we should take reference value that about 10 degree of the angle is of 10 degrees should be reduced from the calculated angle. It should be calculated with the normal reference value.
Okay, thank you, Dr. Amrinder. So we move to the next presentation.
Also, there is another question also.
Is there?
From Dr. Buddhi.
Okay, yes. How many time close reduction is safe before open reduction is mandated?
Could you repeat the question?
How many times close reduction is safe before you proceed with the open reduction? The attempt of close reduction.
Mostly we should uh, uh, do the pinning in the inside to pinning. We should not try for the reduction of the sleep because it will further deteriorate the blood supply of the capital epiphysis.
So how many attempt? I think the question is how many attempt will you try before you choose for open reduction?
In case of acute, if a presentation less than 24 hour, we could try for uh, a closed reduction. We should try for the reduction, otherwise in situ pinning can be done.
Can I add to this? I think this is a
Yes,
very
yes.
controversial thing. Before we actually put up a mark, you said reduction of Sufi. It's very controversial, and people think about it only at in severe situations. I don't think we should completely put up a dictum that you should do a closed reduction or an open reduction. You should look up literature on that, and I think literature doesn't has a very controversial advice on it. So I think the dictum is actually not to reduce unless you go in for a very severe. I've known people managing severe Sufi with osteotomies and things like that. But I think just to say to go and reduce on a normal dictum would not be very fair, I would say. So just be careful. I think I would be careful about trying to reduce a Sufi because it does cause more problems sometimes. Thank you.
Thank you, sir. So uh, we move on to the next presentation. And the next presentation is by Dr. Ayush Restra from Grande International Hospital, who will be presenting on a case of a spinal metastasis.
Am I audible?
Yes, yes, you're audible.
Okay. Okay. First of all, I'd like to thank the organizing committee for giving me this opportunity to present in this esteemed forum. I'm Dr. Ayush Shrestha from Grande International Hospital. I'm working in the spine unit. So without further ado, I would like to start with my presentation. So mainly this presentation is regarded with the decision making in the spinal metastatic disease, especially for the orthopedic and spine surgeons. So actually the spinal metastatic disease, it is a disease that must be managed as a holistic approach through multiple modalities, and multiple specialists must be involved. But mainly the orthopedic spine surgeons are requested to give the proper decision making whether the patient needs surgical stabilization of the spine or not. So let's start with the case first. A 48 years old gentleman presented with uh, he came from the UK, and he presented with low back pain radiating to the bilateral lower limbs, which was the left side was more painful than the right side, and the pain was for 3 months, and it has been progressively increasing in severity for the last 1 month, and the pain was aggravated by movement and activity. So there was no history of trauma, fever, or night pain, or any weight loss. The bowel and bladder habit of the patient was normal, and there was no significant medical and surgical history. So on physical examination, the patient had presented with list, and there was severe paraspinal muscle spasm. On the sensory examination, he had paresthesia on the right side on the L5 dermatome, while the ankle, the reflexes were muted, and the SLRT on the right side was around 70 degrees. So besides that, no other abnormalities were present. The blood parameters were normal. So regarding the neurological deficit and the pain, we opted for an MRI. His MRI showed a pathological fracture in the L4 region associated with surrounding bone edema. And there also was the presence of posterior element involvement, along with the involvement of the sacrum as well as the adjacent ilium. So next we opted for a CT scan which showed lytic lesions in the L4 vertebra as well as the sacrum and adjacent ilium. The patient also had other lytic lesions involving other areas such as the ribs and sternum. So the CT scan, we further investigated and opted for a CECT chest abdomen, which showed a lesion in the lungs. So this was probably the primary site. And so further, due to the accessibility, we opted for a CT guided biopsy from the vertebra, which suggested metastatic carcinoma. So further investigation, we also did a immunohistopathological examination, which showed a high-grade carcinoma with papillary acinar pattern and abundant cytoplasm, which suggested of metastasis from the lungs. So for further management, we evaluated the spinal instability neoplastic scoring system, which showed that the score was a total of 13. So this suggested and advocates for surgical intervention, as it suggests that the spine is unstable. So we also considered the revised Tokuhashi scoring system, and this also suggested that the patient had high score compared a low score. The total score was around 7, which suggested poor prognosis, and the palliative surgery could be an option for this patient. Another scoring system is the Tomita scoring system, which gives the overall prognosis of the patient. In this case, the prognosis of the patient score was around 6. So it suggested palliative decompression. So on further management, what we did was that we basically did the posterior instrumentation to stabilize the spine with pedicle screws in the L2, L3, and L5 region bilaterally, as well as the S2 or the sacral LR iliac screws, which fix the spinopelvic region. So this is the post-operative X-ray, and immediately after the operative procedure, the patient has significant pain relief, and the patient was able to ambulate with very less amount of pain. So spinal metastatic disease, it is, as I said before, it is a disease that requires multimodality approach, and the bone is the third most common site of metastasis, while spine is the most common site of metastasis in the bone. 30 to 70% of the cancer patients, when we do an autopsy, show some degree of spinal metastasis. So, and the metastasis is symptomatic in 10 to 20%, and up to 20% of those symptomatic patients develop the symptomatic spinal cord compression. So the magnitude of this problem is expected to grow as new modalities of treatment are present, and the patients now seem to survive longer. So basically the treatment goals in a spinal metastatic disease should be to maintain and recover the neurological function, pain management, provide adequate spinal stability, and local durable tumor control. So there is a framework that has been devised by a group of spine surgeons, that is the NORMS framework, which includes the neurologic, oncologic, mechanical, as well as the systemic parameters. So diving into each of these, first the neurological parameter, what do we see? Basically, on clinical examination, we see whether there is evidence of myelopathy or radiculopathy. And on the radiological assessment, we do an MRI to see the epidural spinal cord compression level. So this also determines what type of treatment should the patient undergo. Next, we see the oncological parameter. Basically, in this, we see the histology, which helps in determination of the prognosis of the disease, as well as the response to different available therapies, and also the radiosensitivity. So depending upon the type of tumor, the sensitivity of the radiotherapy is present. So this also must be considered. Next, we see the mechanical or the presence of instability in the spine. So usually the spinal instability neoplastic score has been devised. This is very helpful for us spine surgeons to decide whether the patient needs a stabilization or not. So there are certain indications in which stabilization is required regardless of the neurologic or oncologic status. So the spine oncology study group, this was a group of around 30 spine surgeons. We defined the neoplastic spinal instability as the loss of spinal integrity as a result of a neoplastic process that is associated with either movement related pain, symptomatic or progressive deformity, and or neural compromise that occurs under physiologic loads. So the next parameter we see is the systemic parameter, in which we see whether the patient is able to tolerate the proposed intervention that we are planning. So basically, we need to see the burden of the tumor as well as the presence of comorbidities in the patient, so that the treatment that we are proposing, whether the patient will be able to withstand this treatment or not. Next, also we see the patients with the life expectancy of the patient must also be considered, and the scores such as the Tokuhashi scoring system as well as the Tomita scoring system. These are very helpful in determining the life expectancy of the patient. So what are the benefits of stabilization in metastatic spine disease? So in patients who presented with mechanical back pain, the ambulation after treatment in patients with stabilization along with radiotherapy, they found out that immediately after the procedure, 84% of the patients were ambulant, while the patients who had undergone only radiotherapy, only around 57% of the patients were ambulant after their initiation of treatment. Besides that, there was also the evidence of longer maintenance of the ambulation of the patient after the procedure, which showed that if the spine was stabilized along with radiotherapy was given, the average ambulation of the patient lasted for around 122 days, while if only radiotherapy was given, the average ambulation duration was only about 13 days. And after stabilization, they also found out that the need for corticosteroids, opioid analgesics, along with other anti-inflammatory medications was significantly reduced in patients who were stabilized. In general, even though if the patient had short duration to live, the quality of life improvement of the patient was significant. So that should be our main goal. So in conclusion, the norms framework is a useful treatment for management of such cases, even though each case is different and each case has different factors which help to uh, determine what type of treatment to give. This norms framework is a very useful tool and can be used as a framework. The SIN score, Tokuhashi score, and Tomita scores are also helpful in helping us decide what sort of stabilization the patient needs, or whether the patient can or cannot withstand the stabilization or long operative procedures. So basically, the mechanical instability is an indication for surgical stabilization, regardless of the epidural spinal cord compression grade or the chemo or radiosensitivity of the tumor. Thank you.
Uh, Thank you, Dr. Ayush, for your presentation. So I think we have a few questions on the chat box. So the first question is, what difference regarding surgical dissection and surgical procedure while a metastatic lesion is operated versus a trauma case?
So first of all, we need to consider the um, proper workup of the patient before we go for any spinal procedures. So we need to find out whether it is a metastatic disease or a primary disease. So in case of metastatic diseases, sometimes there might be a condition in which the patient has a better localizing area through which a proper biopsy can be obtained. And also we need to evaluate the kind of pain that the patient is having. So basically there are three types of pain that can be generally categorized. The first pain is the localized or biological pain. The localized or biological pain is that sort of pain that occurs mainly due to stretching of uh, the periosteum, or it might be due to increase in the endosteal pressure, or it might be due to the uh, it might be due to the local inflammatory mediators that are released. This also causes pain, but this pain, it is generally uh, uh, occurs only in the morning and evening, and it is not related to the loading. So this type of pain, it does not need surgical stabilization. Another type of pain is the neurological pain that occurs due to compression of the neurological structures. This also depends upon the type of tumor the patient presents with. In certain cases, if the tumor is very radiosensitive or responds to hormones very well. In these cases, even though neurological pain is present, it responds very well to therapy. So these cases also don't need stabilization in many of the times. But the mechanical pain, that is presence due to instability. So this must be recognized, and this occurs due to the pain that is usually due to the involvement of deformity or uh, s- uh, pain that is generated due to compression or instability. So this is not addressed by chemotherapy or radiotherapy, even though the tumor may be well responsive to it. So this must be addressed, and this is usually addressed with the help of sin score. So first, that is, sin score is a very important tool to diagnose the approach to these type of patients. And next is, in case of spine patients, we also need to see the comorbidities of the patient and how long the patient will last. And also, we also need to see whether the patient will be able to tolerate big procedures. So if the patient is not able to tolerate large surgical procedures, which have their own complications, as minimal approach that is possible, that should be done in these cases, unlike trauma cases. Thank you.
Okay, Dr. Ives. There's one more question. Is biopsy required from vertebral lesion for already known case of visceral lesion?
So in certain cases, most of the cases, if the tumor is already known, the biopsy is not required. But in certain cases in which the tumor has been already treated, for example, there was a case in our setup in which the patient had been completely cured through chemo and radiotherapy, and that patient present with another lesion in the spine about around 5 years down the line. So in those cases, what we need to do is that we need to separate whether the tumor is a new tumor that might arise due to chemo or radiotherapy itself. So that is a condition in which we might need a separate biopsy.
Okay, thank you, Dr. Ives, for your comments. So I think we're going to move on to the next presentation. We have Dr.
Anshul,
Lokrat Chor.
yeah.
Yes,
Oh, yeah, okay.
yes.
I was talking about Locas, maybe.
Yeah, yeah. So Dr. Lokrat Chorasia will be presenting from Dr. Lokrat Chorasia from Prithipur Hospital will be presenting on outcomes and hurdles in peripheral nerve surgery.
Can I share my screen now? Hello.
Yes, Locas, you share your screen. We can hear you. Your audio
You are
is not
all.
clear.
I think there is some disturbance with the sound.
I muted.
Dr. Lokrat, you may begin.
Locas, you are muted.
Yeah, I am unmuted somewhere. The host has unmuted.
I think maybe Locas, you sort out with your audio problem, and maybe Anshul, we can go ahead with another presentation, and
Sure,
Locas
sure.
can
Then
join. Because
Yeah,
there's
no, the host has. Can I start now? Am I audible now?
you are audible, but there is some kind of disturbance on the background.
And do you have two devices at the same place? That might
No,
be
no,
causing the
no,
sound.
no, no.
It's your earphone. Please change your earphone. Use your earphone present in your laptop.
You can change your earphone or headphone.
Yeah. Can I? Am I audible now?
Yes, yes, yes. You are now audible and visible.
Okay.
You
Yeah.
may begin.
Okay. So I would like to start. Good morning, respected seniors, my colleagues, my friends, and my loving juniors. So I'm going to present over outcomes and hurdles in peripheral nerve surgery. Um, and I'll be presenting our census for 1 year. Within the peripheral nerve surgery, I'll be presenting brachial plexus as a separate topic. Okay. So in the last year, year 2077, we had a total of 87 cases, of which we treated or operated on only 62 cases. So this is the census. If we see the census, we have more number of brachial plexus as well as obstetric brachial plexus palsies, but we operated on only 11 brachial plexus injury patients, and we did not operate on any of the obstetric brachial plexus palsies. And three brachial plexus injury patient and one tourniquet palsy, they were treated non-operatively. So coming to the peripheral nerve injuries, like the most common pathology or mode of injury was laceration or cut injury, followed by loss of nerve. Then we had more compression injuries, of which within the lacerations we had 12 or 25% was there was a significant loss of nerve. So we will be discussing each pathology separately. Within the compression injury, the most common cause was a neuroma, specifically digital nerve neuroma of the index finger, followed by the cyst and lipofibroma. And within the left lower figure shows digital nerve neuroma in a 22 years lady who had um, ray ray resection of index finger following a blast injury, and the lower right shows a neuroma in a crush injury in a 53 years old male. We can clearly see the neuroma in the left as well as the right figure. And the cyst was the next common lesion causing compression. And this lady, a 55 years lady, she presented with lipofibroma, histopathologically confirmed, and she only had neu- ulnar sensory symptoms, no clawing or any other motor symptoms. So we can see the mass was encircling the ulnar nerve, and after excision, in the red loop we can see the median nerve as well as the brachial artery and the cut section. So this was confirmed as lipofibroma. Now coming to compression pathology, the most common compression was of ulnar nerve, uh, followed by median nerve. So the cubital tunnel was the most common site of ulnar nerve. We also had a radial nerve compression, in which the radial nerve was compressed between the plate and the humerus. So decompression was the most common mode of treatment. And for the radial nerve we had nerve transfers to be done, and we transposed on a nerve in just one case. So in the left lower figure we can see the Guyon's canal with a cyst in the background and on a nerve. Similarly, on the lower right, we can see on a nerve after decompression in cubital tunnel. Uh, this case is a case of heterotrophic ossification with ulnar nerve. So we decompressed, we removed the ossification mass, as well as we also transposed the ulnar nerve anteriorly. And this is a radial nerve being entrapped between fracture humerus and a DCP plate. So the blue loops, they show the radial nerve being trapped proximally as well as distally. So coming to laceration, uh, again, ulnar nerve is the most common laceration, and we had more number of ulnar nerve loss, as can be seen in the numbers, and we also had radial nerve and also digital nerve. For these lacerations, uh, the most common treatment modality was coaptation of the nerve using microsurgical technique. We also had to graft, uh, and we grafted median nerve in 3 cases, of which the graft length was 7 centimeter, and ulnar nerve graft of more than 7 centimeter was required in 3 ulnar nerve cases. So similarly, this is a clean spaghetti wrist where we had all wrist flexors, finger flexors, and median and ulnar nerve injury. So we repaired, and all the tendons, arteries were anastomosed, and the nerves were coapted. And this is her follow-up at the end of 7-8 months. We can see good and we saw good hand sensory recovery. We also have good motor recovery. In the lower right, we can in the right most picture we can see intrinsic position of her hand, and this is her function. She is also able to uh, we can see making her a normal grip, as well as she can also perform her normal fine movements. So similar case, a 34 years male with a 2 months old laceration over wrist with ulnar symptoms. So in this case, we can see a scar. So on exploration, we had a 2 centimeter gap in ulnar nerve. So we grafted it with 3 cable grafts, two for sensory and one for motor function of ulnar nerve. So this is the final picture at 6 months follow-up. We can see absent ferment sign as well as good intrinsic hand position and absence of clawing. So we can also see good fine movements as well as individual finger movements, which is possible with nerve grafting, but not possible with tendon transfers for ulnar nerve symptoms. Okay. Coming to this topic, the nerve transfer. So, sorry. So coming to nerve transfer. So we had uh, more commonly anterior introstatic nerve to ulnar motor transfer was the most common, followed by recurrent motor, and we also had median to radial nerve transfer. So this case, a 24 years female with shaft of humerus fracture. Plating was done outside, not in our center, and following that, she had radial nerve palsy. She presented to us 4 months after injury. So we can see a wrist drop as well as a finger drop. And this is our clinical picture, no wrist extension as well as MCP extension. On exploration, we had radial nerve entrapment between the plate and the humerus, as seen the proximal end and the distal end of the radial nerve. So we uh, had a median to radial nerve transfer. FDS was transferred to ECRB branch and FCR to PIN. So in the 11-month follow-up, we can see she has good wrist extension. She can individually flex and extend her fingers, good thumb IP movement. So in this video, we can see a normal mechanics of the hand. Again, this is not possible with tendon transfers. So similarly, another case of 7 years female with Montesia fracture dislocation, open reduction was done at another center, and she had presented 7 months with ulnar clawing. We can see ulnar clawing along with wasting of her hypothenar muscles. So again, on exploration, there was a nerve gap of ulnar nerve. So we grafted for sensation, and AIN in the lower right, you can see AIN to ulnar motor nerve transfer was done. So at the follow-up at 1 year, so she has a Wattenberg sign, but she has no clawing, good intrinsic function. And this is a pre-op. We can see a clawing. Follow-up at 1 year, we can see she has good and no clawing, good wrist and fist movement, and also she can make a good individual finger movements. So again, these results are not possible with tendon transfers. Okay. Now coming to brachial plexus palsies, like we had 27 cases of adult brachial plexus palsies who presented in different duration of injury. However, we were able to operate on only 11 cases. 8 cases of obstetric brachial plexus palsy presented to us, but we were not able to uh, operate even in a single case. So we'll be discussing about the hurdles in the last. So Among the brachial plexus injury patients, we had like C5, C6, and C7 root involvement as the most common form. And then we had C5 and C6 root involvement. And again, in two cases, lateral and middle cord were involved, and posterior cord in one, and total plexus palsy is only one. So this is a 34 years male with right hand dominant. He had C5, C6 involvement, and he presented 8 months post injury. So we explored, and we had three nerve transfers. So the leftmost is spinal accessory lower center one is radial nerve of triceps to anterior axillary nerve, and the lower right is Oberlin 1 and 2 transfer. So this is his pre-op on the left most side figure, and this is follow-up at 9 months. So it is just 9 months. So he also has M3 power of shoulder abduction about 30 degrees, but M2 power of uh, M2 power of shoulder abduction, as seen in this video, and he can fully abduct. So he is currently under strengthening of his shoulder right now. Okay. So this is follow up at just 9 months. Okay. So similar another case of brachial plexus injury, a 22 years male with winging of his scapula, as seen in the figure, I mean in the picture, with unstable shoulder. He presented almost 1 year after injury, so exploration was done, and a decompression and neurolysis was done. In the nerve hook, we can see the long thoracic nerve and the long thoracic nerve in the nerve hook, and the C5 root, C6, the middle trunk, and the superior trunk. And then again in the lateral side of chest, the long thoracic nerve can be seen. It was decompression was done. You can see few vessels that were compressing the nerve. So this is his pre-op with unstable shoulder, and this is a follow-up picture. So So the hurdles during treatment of all these patients that we felt, it's my individual perception. So we had, I think, a lack of awareness was most common among our fraternity as well as the patients. There was also quite late referral. So we had good results in early referral and poor results in late referral. Counseling on, I think, the surgeon's part, myself, even that was lacking at some places, and even the surgical skill, my own expertise, our team expertise, and still needs to be improved. And since there is a very long treatment protocol, like 2 years or 5 years, so even a patient compliance, like usually the patient gets treated and then they are lost until and unless they come some with some again problem. Then again, one is the, like, we are not in all these nerve surgeries, we do not get the 100% the previous normal. So many a times, like the patient expectation and our scenario what we can offer, there is a difference. And also, like, a very large team is required. Like, we cannot keep any patient for 2 years in Kathmandu for treatment. So for all these, like the collateral support, like a physiotherapist, the electrical stimulations, all those are not accessible at all parts, and also we cannot ask the patient to stay in Kathmandu at all the times, and financial issues, and there are many more which I haven't mentioned probably. So the take home message for this is like early diagnosis and treatment. This can lead to a better outcome. Microsurgical skill is a must in peripheral nerve surgery. Nerve surgery gives better outcomes than tendon surgeries, And this is a timetable uh, which I think is appropriate as per our institute. Different surgeons can have different time of intervention. So for a peripheral nerve injury, 3 to 4 months. For partial brachial plexus injury, 2 to 4 months is the appropriate time. For total plexus injury, 1 to 2 months, and obstetric brachial plexus, 3 to 9 months. So this is the approximate time which is optimal for the patient to be intervened. And with as we keep on losing time, we keep on losing nerve. So time is now, and so we all need to work better for the better outcome of these patients. So this is our unit involved in all these peripheral nerve surgeries. The Dr. Kiran Nakarmi, is also our HOD, and we have two physiotherapists, Mohan Dangol and Nashla Manandar, taking care of these patients. Thank you. So
Thank you, Dr. Lokras, for the wonderful presentation. So we have a few questions. How do you differentiate between type 2 and type 3 obstetric brachial plexus injury clinically?
so basically, in the obstetric brachial plexus, um, like as we know, like we have like 80% they recover, the type 1 and type 2. So in 80% we have recovery, so that recovers by 2 months, 2 years of age. So at the 3 months of age, we can have a Gilbert test, and at by 9 months, we can have cookies test. So by these two tests, we can differentiate whether this patient is going to improve or not. So if this patient, if we see features that this patient is not going to improve, we intervene them by 3 to 9 months of age. So if these patients they are not going to improve, like if they are going to improve, we can continue with the conservative treatment and physiotherapy. But if these are not going to improve, we intervene by 3 to 9 months of age. Like what is the trend is like most of the obstetric brachial plexus palsy, they come around 2 years of age. So by that time all the neuromuscular junctions they have degenerated. So by that time, like after the neuromuscular degeneration, we don't have any surgeries for that. We can only offer them tendon surgeries, which the patients are usually not satisfied. So if we identify this group of patients with the help of Gilbert test and cookies test by 3 and 9 months of age, we can intervene in these children quite early.
Thank you. I think we can take one more question. What is your opinion regarding tendon transfer and nerve repair at the same time in the late radial nerve injuries?
Uh, in tendon transfers, like usually we see uh, there are some demerits, there are some advantages as well as the disadvantages of both the surgeries. Like in the tendon transfer, if we have a radial nerve, like in my uh, video. So what happens when you do a tendon transfer for a radial nerve injury? Usually there is some power loss. Okay, there is some power loss, but with nerve transfer you can have a normal power. Okay, in this video, all those nerve transfers, we can have a normal power. You will have a normal mechanics. So in a radial nerve transfer, when you go for a median to radial nerve transfer, so what you see when you go for a tendon transfer, so what you see, like you do not have a normal mechanics, like the thumb, it doesn't move like as normal, it moves somewhere abducted wise. So you do not see that, and you do not also have, like we have EDC, in we have the donor tendon attached to the EDC. So you again do not get individual finger movements. So in these videos, in all these nerve transfers I've shown, like the patient they can have a normal movement, a normal fine movements, which is the requirement. Like even in this video, if you see, we get a normal individual finger movements, which is again not possible with tendon transfer. So, but the only problem with the nerve transfer is that it needs to be intervened within the appropriate time. Okay, whenever we see a tendon transfer picture, like they show gross movements, they do not show all these fine movements. But the advantage of tendon transfer is it can be done at any stage, like 5 years, 10 years, provided the joints are supple and we have good donor tendons.
Okay. Thank you. There are few
Excuse me.
more. Yes.
Regarding the first question, that how to differentiate type 1, type 2, or type 3 obstetrical palsy, I would just like to highlight that type 1 is predominantly the C5 symptoms, root symptoms are there. Type 2, C6 and C7 are there. And type 3 is a complete flaccid limb. So it's a C5, C6, C7, and 8. And there is one more, that is type 4, that if it is associated with Horner syndrome, it's mostly seen in the cases of children. That is the type 4. That is the simple clinical evaluation of type 1, and to differentiate the type 1, type 2, and type 3.
Thank you. Thank you for the comment. So I think we'll move on to the next presenter. The next presentation is by Dr. Prabir Shrestha from BNB HRG Hospital, and he'll be presenting on salvaging hip with pelvic support osteotomy.
Is my slide visible?
Yes, Prabir, it's visible. You're audible.
Good morning, everyone. I am Dr. Prabhu Shrestha from FCPS final year resident from BNB and HRD Hospital. Today, I would like to talk about salvaging hip with a procedure called pelvic support osteotomy. Uh, in most cases of post-infective hip, as we know that septic hip arthritis is an orthopedic emergency. If not treated properly or at timely, the consequences can be devastating, such that the degree of damage and the eventual outcome following the septic arthritis are very difficult to predict, even if the patient has an appropriate treatment. However, we can identify the prognosis depending on mainly upon two main factors, that is early detection and adequate treatment. If the case is detected early and gets adequate treatment, the prognosis can be favorable. If not, the consequences can be devastating. And other risk factors are prematurity, age of the child, if it is less than 6 months of age, the type of bacteria, or if there is a concurrent osteomyelitis of the diaphysis, or if there is septic dislocation of the hip joint. However, when this patient present with a post-infective hip or the sequelae of hip, uh, usually most of the patient can be asymptomatic and are identified only incidentally, but they mostly they present with a complaint of pain over the affected hip, with an associated stiffness or restriction of the motion of that hip, and instability, mostly due to the damaging of the stabilizing factors, limb length discrepancy or with an equinus foot, because due to the damage at the physis or the growth areas, due to which the patient can present with a limp, uh, or pain around the back, knee, or contralateral hip, or visible deformities. In our scenario in Nepal, usually due to the lack of awareness or healthcare providers at the rural areas, this such infective hips are presented late. As we can see in this example X-rays that I've shown, they usually present late with an obvious deformity or sequelae. So there are multiple classification for this. First was devised by Hunka classification, where he has classified the post-sequelae hip according to the changes in X-ray and presence and absence of femoral head, which was more further uh, modified by Choi, which has devised a clear classification based on the nature of injury, clinical and radiological configuration. However, this classification was difficult to use as there was vast intra-observer biasness or intra-observer interpretation. So there was further modified by Forlin and Milani into a simple two grade where they considered the either the hip is dislocated or not, or the femoral head is present or not. This is the classification that we use to classify the post-infective hip, and according to this, we advise for planning for the surgeries. So coming to treatment option, it vastly depends upon the age at presentation. When the child has presented, either it is early on presentation or late, and the status of the hip, either the hip is dislocated or not, or there is a femoral head is present or not, or the patient is skeletally matured or not. So depending upon them, there are multiple uh, choices for the treatment. There are surgical self dislocation with osteochondroplasty, orthodesis, a Wagner neck lengthening, or trochanteric orthoplasty, or a femoral neck reconstruction. But today I will like to talk about a pelvic support osteotomy, uh, which is a salvaging hip salvaging procedure for basically for skeletally matured adolescent children. As this is a salvage procedure for adolescent or young adult who has a painful limb with a restriction of hip motion and early onset fatigue due to walking as a consequence of his destruction. It is a double level osteotomy of the femur. The proximal is a proximal osteotomy is a valgus extension osteotomy, which when performed it lateralizes and distally displaces the greater trochanter, which helps to increase the abduction abductor muscle or abductor lever arm, and also creates a fulcrum at the medial end of the pelvic support. Another is a second distal osteotomy, which helps to restore the orientation of the knee and the ankle joint lines in the coronal plane and provides a focus for femoral lengthening if there is a presence of limb length discrepancy. So, on all in all, pelvic support osteotomy reduces the limb through abolishing the tendon lurch, equalizes the limb length, and through the stability provided, it facilitates a more energy efficient gait. So for indication, the indication of pelvic support ostomy is first and foremost, it is the sequelae of the post-infective hip, usually presenting late, mostly fall in type 2 or type 2B. Other is a patient with a gallstone arthroplasty, or in a case of unsuccessfully treated or neglected congenital hip dislocation, when there is a femoral neck pseudoarthrosis, or in a patient where arthrodesis or hip arthroplasties are not appropriate. And the aim of our treatment or using pelvic support ostomy is to improve the abductor insufficiency, correction of the malalignment or deformities, achieving a stable hip joint, and correcting the limb length discrepancy. However, there are a few contraindications, such as it should not be performed in a younger child that is less than 12 years of age, because of the rapid remodeling, rapid remodeling at the proximal femoral site, femoral ostomy site, which recreates leg length discrepancy by skeletal maturity. Or an older patient in whom total hip replacement is a better alternative than pelvic support ostomy, or a chronic paralytic hip dislocated patient in case of non-ambulating patient. So for planning for a pelvic support osteotomy, clinical examination is a must. Along with it, for planning for the osteotomy, uh, uh, a full-length anterior posterior view of the both lower limbs with patient standing is essential, as it helps to show the pathology, hip pathology, as well as the limb length discrepancy or other deformities around the femur and the tibia. An AP view of the pelvis with an affected hip in maximum abduction. This helps to show if there is any presence of any adduction contractures, and a maximum adduction cross leg view with both ways showing. This helps to demarcate for the proximal femoral osteotomy site. So for the proximal femoral osteotomy site, the level of osteotomy can be depicted as as shown earlier. The maximum adduction cross leg view of X-ray is done, and a line, vertical line from the pelvis and the mechanical axis of the anatomical axis of the femur is usually at the when it crosses at the level of ischial tuberosity. This is the level of osteotomy. So after performing osteotomy, we have to create a valgus angle correction. Uh, there are multiple methods are present. However, this is very controversial. Uh, This can be depicted by an estimating sum of measured range of adduction plus the size of adduction contracture if present, or by calculating the valgus angle by using the formula where a complementary angle we calculate a complementary angle to the pelvic mechanical axis and then adding 15 to 25 degrees. This 15 to 25 degree is the angle of overcorrection. As I've already said, there is chances of remodeling. So this 15 to 25 degree is empirical to add for the correction of valgus angle, so that later when it remodels, this angle is can help. Another is distal femur osteotomy. It is done at the level intersecting the vertical axis from the pelvis and the anatomical axis of the tibia and femur where it intersects. Uh, this is the site of the distal femoral osteotomy, and to it, some certain degree of varus or deformity can be corrected, and during the correction of the varus, it should be made parallel to the pelvic. The knee joint and the ankle joint should be kept parallel to the pelvis in the coronal plane, and it should be kept in ostomy should be done in such a way that the knee joint is equally from the midline from the for the in comparison with the contralateral leg. So, however, there are complications for using this procedure, as it can cause, this is a prolonging procedure. Uh, there is a complication such as knee stiffness, premature consolidation of the lengthening, uh, lengthening at the ostomy site, or proximal migration of the femur, common penile nerve palsy, loss of angulation of femoral, proximal femoral ostomy when performed in a younger child less than 12 years age, femur fracture, or even a mild knee subluxation. However, this pelvic support ostomy can be done as a single stage procedure or a double stage procedure. Single stage procedure, it is usually done with a rail fixator, such as we can see in this clinical picture, where a rail fixator can be used for proximal as well as the distal. As we can see in this X-ray also, this is the proximal ostomy site, and this is the distal osteotomy site. However, using a single stage or a rail fixator for this single stage pelvic support ostomy, there is we faced complication. We faced multiple complications, such as which is most common was the varus deformity distally, which was not we are not able to correct when using a rail fixator. So to overcome this, we did double stage or two stage pelvic support ostomy. In the first, we did a proximal osteotomy fixation with plate at the proximal osteotomy site, and then in second, we did varus correction and lengthening with Ilzaro, as we can see in this clinical picture. This helped to overcome the complication that we saw in the single stage, the varus deformity, as well with the help of Ilzaro, we had a controlled leg lengthening also. So I want to talk about few cases. The first case, this is a 14-year-old male child presented with a complaint of um, shortening of his left hip, left lower limb with an difficulty in walking. He had a history of infection around his hip at the age of 15 months of age, which was treated surgically, and now he walked with uh, uh, a antalgic gait and with lurching, as we can see in this video. The patient has an equinus gait and with a significant shortening of this left lower limb with a lurch. So this was his pre-operative X-ray, where we can see there is a proximal migration of his femur with an absence of femoral head. So we planned an pelvic support ostomy with a single stage where we use a rail fixator. This was the immediate post-operative picture, where we can see the rail fix. This is the proximal ostomy site, distal ostomy site with the rail fixator. And at the 2-month follow-up, we can see a good callus formation on the both sides. This is the clinical picture where we can see the use of rail fixator. At 4 month of follow-up, the rail fixator was removed and a single hip spica was applied. And finally, we can see a good healing of at both the proximal and the femoral osteomy site. This was his post-operative picture, uh, where we can see a good alignment of the deformity. However, this patient had few complications such as knee stiffness, infection at the pin tract, and loss of decrease in power due to the knee stiffness. So we like to present another case. This is also another 14-year-old female child who presented with a shortening of her right hip with difficulty or pain while walking, which was noticed since her walking age. There was no any clear history of trauma or infection provided by her parents. There was a limb length discrepancy of around 5 centimeter, and this was her gait. She has an antalgic gait and with a lurch. So this was our X-ray operatively, where we can see there's a proximal migration of our proximal migrated femur with dislocation and with an absence of femoral head. So we did a double stage or two-stage pelvic support ostomy, where initially we did the proximal femoral site ostomy and used a plate to fix it. This is at a 3 month follow-up where we can see a good callus formation and healing. So after 3 months of follow-up, we then did a second stage osteotomy at the distal femur site and we kept an Eliza rope. This is our clinical picture. We can see a good femoral varus alignment. So this at 1 month follow-up, we can see a good callus formation or newborn formation following a limb lengthening. And at 8 month of follow-up, we can see a good alignment and a good callus formation of the distal femur also. So all in all, in conclusion, pelvic support ostomy offers a significant improvement in posture, gait, and walking tolerance to those adolescent and young adults who have hip disturbed by the neonatal sepsis or who have undertreated congenital dislocation. However, a preoperative consideration involve a careful clinical as well as a radiological assessment together with a discussion of alternative surgical solutions. The surgical planning is based on a data obtained from the clinical and X-ray assessment, both which will provide the surgeon with the answer to the level, the amount of valgus correction, the extension and the derotation at the proximal ostomy site, and the level and the amount of varus as well as lengthening at the distal ostomy site. Thank you.
Thank you, Prabhat, for the presentation. We have one question. What plate is used for fixing an ostomy site?
We can use a simple dynamic compression plate.
These are
We have
simple
to keep
DCP
in mind that
plates that we have used.
we can use simple DCP plate, which is easily available, but we have to make sure that the plate is bent according to the femoral osteotomy site.
Okay, thank you, Prabhat. I think we'll move on to the next presentation. The next presentation is by Dr. Vikas Parazuli from Thulikel Hospital, who will be presenting on high anterior cervical retropharyngeal approach to the upper cervical spine.
Am I audible and is my slide visible?
You're audible, but the slide is not visible yet. You can start sharing your slide.
Yeah, I'm trying it. It says resume share, but it's not working. I don't know why.
Okay, the slide is
Yeah,
visible.
it's working now.
Yes, you may begin.
Okay, so good morning, all my respected seniors, my colleagues, and my beloved juniors. So today I'll be talking about high anterior cervical retropharyngeal approach to the upper cervical spine. We all know that the anterior upper cervical spine, it has a very complex anatomy. Like as you see in this figure, there are lots of structures in and around, and approaching the upper cervical spine, going through these structures, it looks quite scary. But it's not that scary as it looks. And the retropharyngeal approach, the main advantage of this approach is like you can access the cervical spine from craniocervical junction up to the cervical thoracic junction. There is one approach which is transoral route, though it's a very direct approach, but it has some limitations, like it cannot be extended inferiorly, and it uses a contaminated surgical corridor. Like you can see in the figure, it goes through the oral cavity, and this oral cavity with the pharynx is the contaminated corridor. So there are always chances of infection, and it's because of that it's unsuitable for the placement of allograft or instrumentation or to do some intradural work through this approach. So because of this limitation, we have another approach which is relatively safe. Uh, it is high retropharyngeal approach, and you can always do anterior stabilization, including C2, C3, and you can even work in the anterior arc of C1, and it can be done without much of severe morbidity. So coming to the approach proper, this is the classical approach that has been described, though we don't follow this particular approach here in Dulikal Hospital, but I think it's better to know what is described in the literature. So the patient positioning is with the patient's head slightly extended and rotated 30 degrees to the right or left. So it has been advised to approach the cervical spine from the left just to preserve the recurrent laryngeal nerve, but it depends upon the surgeon's choice whether to go from the right or the left. And usually, if a surgeon is right-handed, then he prefers going from the right because it's easier to work from this side. So once you, okay, just look at the incision. The incision, it's a transverse incision that just is starts from the midline, and then it goes up to the angle of the mandible, and it laterally up to the angle of the mandible, and it can be extended posteriorly up to the mastoid. So this is quite a huge incision, and this incision can always be extended with a longitudinal incision running down. So it gives a T-shaped incision. So if you run it down, then you can go up to the cervicothoracic junction. And once you give the incision, and then you come across the platysma. So platysma is excised in line with the skin incision, and after that, the first structure that you need to dissect is the submandibular gland. So if you want a very thorough exposure, then you can always excise the submandibular gland, but you can preserve it. So once you identify the inferior areas of the submandibular gland, just beneath it there is the anterior digastric muscle. Okay, so this is the submandibular gland, this is the digastric muscle, and just below there is the hypoglossal nerve. So it runs posterior to and parallel to the digastric muscle. So once you go even below this, then you encounter the superior thyroid artery, which usually has to be sacrificed. So you need to properly ligate it and then sacrifice it. And with further going posteriorly, then you reach the cervical spine, the upper cervical spine. So the working corridor is again just like the retropharyngeal approach of the subaxial spine. So it is in between the trachea, esophagus, and the strap muscles, and the sternocleidomastoid muscle. So you are medial to the sternocleidomastoid and lateral to the strap muscles and trachea and esophagus. So this is the schematic drawing showing the final uh, picture after the approach. So here you can see the submandibular gland, the digastric muscle, the hypoglossal nerve. It is retracted superiorly, and then these are the midline structures, and usually this is where the cervical spine lies. And this is the final schematic picture. Like once you properly dissect the overlying fascia, then you see the anterior tubercle of C1, and you can see the C2, C3 disc space here, and the longer scoli muscles are visible. So these longer scoli muscles, these are dissected laterally and superiorly for our exposure, proper exposure. So this was in brief about how this approach has been explained conventionally, and there are it's not out of complications. So there are lots of complications. So most common complication is dysphagia, and the principle of this approach is once you go in, you need to be very liberal in dissecting the fascial planes so that the other structures do not get tethered into those fascial planes, and they can be mobilized easily in the required direction. And the other complication can be submandibular gland injury. There are three nerves that are a potential danger, like hypoglossal nerve that I will show in the figure. The superior laryngeal nerve, it lies at the deepest part of the exposure, and it is adjacent to the C2, C3 discs. So once you feel the C2, C3 discs, you should be careful to not to injure this nerve. And marginal mandibular branch of the facial nerve, there is a high chance of injuring it if your incision is um, uh, your incision is not below the angle of or the margin of the mandible. The other rare complication can be esophageal perforation, and yes, if you are working in the dura, then CSF leaks are another complications. And if there are CSF leaks, then you have to identify it then and there. So if you come out of the surgery and in the post-operative period, if you find out a CSF leak, then that becomes a disaster. So now coming to a few of the cases that we have done through a modified version of this approach. The first case is 8 years old female who complained of clumsiness of hands and difficulty in walking for 2 years. And her neurology, she had right-sided upper limb weakness. The sensory was intact, sensations were intact, and she had spasticity, ankle clonus, and bilateral plantars, they were upgoing. This is the plain X-ray of the same patient in flexion and extension view. So though it's not so clear, but you can see there is some amount of instability with every flexion. You can see whole of the hair is moving out, and the whole of the cervical spine is moving posteriorly. So there is atlanto-occipital instability in this patient. So we further investigated the patient with CT, and you can see this is the C2, and it has been reported as a fracture of C2, but the patient doesn't give a significant history of trauma. So we diagnosed this case as an os autointerium that is invaginating into the spinal canal in C1, C2 junction. This is the MRI of the same patient, where you can see there is a very small space for the spinal cord at this region. Initially, we had planned for all posterior approach for this patient, but by looking at the 3D reconstructed image of the upper cervical spine, we see that the patient has some congenital anomalies of C1 and C2, and she had a very dominant kind of right vertebral artery. So there was always a very high risk of injuring this artery when we go all posterior. So that's why we planned for uh, an anterior approach first, and then in the second stage going for the posterior approach. So this is how we position the patient. Unlike I explained earlier, like tilting the head on the opposite side by 30 degree, we just keep the patient in with the chin in the midline. So this aids in helping us to, it helps us to know exactly where the midline is. So there will be two bony landmarks for us, and this is the amount of incision that we usually give. So this is the patient. This is the upper. This is the cranial end. Here is the chin of the patient, and this is uh, the incision that we have given. And once we dissect the platysma, and then we we make a plane between the strap muscles, the carotid and the strap muscles, esophagus and the trachea, and the sternocleidomastoid. We go deep, and the only structure that we frequently encounter that needs to be sacrificed is the superior thyroid artery, which we ligate and then we sacrifice it, and we go further deep, and then we just put the tubular retractor that we usually use for micro discectomy. So this is the same tubular retractor that can be used in this approach also. And this is how it looks, though it's not the field is not in focus, but still you can see this is the body of the C2, and then further up you can go up to C1, and this is the odontoid process that uh, we targeted in the surgery. So this is the video. It's a very short video, but this is how it looks like. Mhm. And once we completed the anterior surgery, the next day we planned for the occipito-cervical fusion of the patient. So post-op, this is the post-op X-ray, and this is the post-op 3D reconstructed CT. So in the second figure, we can see the canal is well decompressed, and just to avoid the right-sided vertebral artery injury, what we did was we extended the construction of the C3. So we use bilateral C3 pedicle screws, and in the left side we use C2 pedicle screw, and on the right side, instead of a C2 pedicle screw, which was very risky, we used laminar interlaminar screw for fixation with the occipital plate. And this is the post-op CT, where you can see there's no odontoid process here in the middle. It has been, and the canal has been well decompressed. And again, comparing the CTs, you can see the whole of the odontoid could be removed with this approach. And that day, we just kept the patient in skull traction for stabilizing what we have done anteriorly. And then well, the next day, we stabilized with occipito-cervical fusion. So the patient has been discharged, and there was no uh, significant complications that we noted. And we usually do these kind of surgeries with full neuromonitoring. So risk of spinal cord damage is also quite less with the use of neuromonitoring. This is another case, which is a 63 years old female with the complaints of generalized spasticity, difficulty in walking for 8 months. She gives a history of trauma 8 months back. Again, she has Hoffman sign positive with inverse radial reflex positive, and motor. She had 4x5 power bilateral upper and lower limb. And this is the X-ray of the patient, where again we can see some signs of instability in the atlanto-occipital junction. And this is the CT of the same patient, where you can see the odontoid has invaginated into the foramen magnum, and you can see the C1 assimilation is there. That is, the C1 is fused with the skull. So again, this was some kind of anomalous C1, C2 that we got. And this is the actual section, where you can see the tip of the odontoid process is right at the center of the spinal canal. And this is the MRI, where you can see the patient had compression at the level of C1, C2, and also at the level of C3, C4 disc. So this was also addressed later on. And ongoing with the vertebral angiography, what we found was the patient has an anomalous course of the vertebral artery in the right side. So this was probably a persistent post intersegmental artery, and going dissecting this artery and going into the C2, this was again very risky. So because of
Excuse
that,
me, Dr. Bikash.
we just planned for the anterior approach. So anteriorly, I have not kept the power pictures, but you can see this is the pre-op CT and this is the post-op CT, where the tip of the odontoid has
Dr.
been.
Bikash, can you try and conclude, please? We're running late here.
And there is also the reduction of the C2 odontoid, so it has come down. And what we did was we just placed spacers in both the C1, C2 facets anteriorly, And this is the CT showing the same thing. And this is the coronal section with the spacers that have been placed in C1, C2 junction. And this is the post op CT showing a good amount of decompression of the patient. So, concluding my presentation, the take-home message is this approach can be done with smaller incision and lesser amount of soft tissue dissection. It's a very useful surgical technique without severe morbidity for an upper cervical lesion, and it gives direct access, anterior access to C1, C2, and C3 while allowing extension to the lower cervical spine. So with this, I'd like to conclude. Thank you.
Thank you, Dr. Vikas, for your presentation. We have already exceeded our time limit, so we'll move on to our next presentation by Dr. Vivek Basukola from BNB HRG Hospital. We'll be talking on pediatric ACL reconstruction, our preferred technique.
Am I audible and my slides are visible?
Yes, sir, you're audible and visible.
Okay, thank you. Thank you, Ansur. Respected seniors, colleagues, I'm Dr. Vivek Basukala. I work in AKB Center for Arthroscopy, Sports Injuries and Regenerative Medicine. Today, I'm going to talk about less discussed topic in sports medicine in our country, that is pediatric ACL reconstruction and our preferred technique. So as we all know, children are very great creation of nature, and childhood is the best time we all could have. The children in this age group are very innocent and they like playing and they are very cheerful. One reality and one characteristic of this childhood is they grow. The child gradually grows into the adulthood. So, and another reality and another characteristic of these children is they are really playful and they do not miss any chance of playing. And these, as we all know, because of increased competitiveness in today's days, the pediatric has become very competitive, and because of school level participation in sports, even the pediatric sports has become very competitive. And needless to say, if the pediatric competitive sports increases, the pediatric knee injury is also going to rise. This is 20 years retrospective study analysis published in Pediatrics Journal, and it shows that the incidence of ACL injury is rising in 20 years time, and that is more so in female population. So when we deal with these pediatric population, what we must have in our mind is that the popular saying in our medicine that is children are not small adults. There is difference between these two, children and adults. The difference is the physis. These physis are very, very important, and these physis leads to the growth, longitudinal growth of that particular child, with which he or she becomes adult. So this injuring these physis is maybe very, very morbid condition, may lead to multiple deformities in the future. So whenever we deal with pediatric population with ACL injury, we should think about these physis. So ACL tear in pediatric population, there are various management protocol. First one is non-operative management. Second one is operative management, and there is middle path regimen, that is to delay surgery till the physis is fused. And non-operative treatment is usual treatment in Nepal, maybe because of fear of injuring the physis and because of fear of future deformities. So we have started some operative management in some of our pediatric population. And what happens if delayed? If the surgery is delayed in population, as we all know from adult literature, that if surgery is delayed in adult population with ACL injuries, what happens? There is recurrent instability, and because of these recurrent instability, there are secondary injuries to meniscus and cartilage, because of which there will be more injury to that knee. And as we all know, reconstructing isolated ACL injury, the results are far superior to reconstruction of ACL, along with secondary procedures to cartilage and meniscus. So what we must realize that these all the high level sports person were once children, and if these sports person would have sustained those type of injuries, and if they were denied some form of treatment to have their knee perfect, to make their knee perfect, then these players won't be there. So what I mean to say is, some of our children who are very active in sports might have this future. In future, they may be the elite sports person. So they must not be denied any form of surgical treatment. So that surgical, coming on to surgical treatment, the surgical treatment can be extraphyseal, where no tunnels are placed. They may be all epiphyseal technique, where no physes are damaged, and there may be partial transphyseal or transphyseal technique. So with no tunnels, extra epiphyseal, all epiphyseal techniques are reserved for prepubescent Tanner 1 and 2 if less than 10 years, if more than 6 years of growth are remaining. Then all epiphyseal technique where the femoral epiphysis and tibial epiphysis are drilled, they are reserved for Tanner 2 and 3, and if age is more than 10 years, and if 3 to 6 years of growth are remaining. Then another one is partial transphyseal. Partial transphyseal, the principle is the tibial physis closes earlier than the femoral physis. So we do transphyseal drilling from the tibial side and all epiphyseal drilling in the femoral side. That is if less than 3 years of growth remaining. And next one is as the transphyseal, that is we drill through the physis from the tibial and femoral side, and these techniques are usually reserved for pubescent Tanner 4 and 5 if patient is more than 13 years and if nearly 1 year of growth is remaining. So let us discuss a case of ours. He was 13 years male. He presented to us with history of twisting injury 2 years back, following which he had rapid swelling of his right knee joint, and he continued. He felt better with some icing, he felt better with some medication in about 2 weeks time, but he continued his sporting activities, and he presented to us with repeat twisting injury. And while we obtained the knee x-ray, plain x-ray of his knee joint, this was the plain x-ray, so we found that both the physes were not fused. So this is clinical picture of that particular patient. What we found was varus valgus stability was okay, that the anterior stability was not there. The Lachman was positive. The Lachman test was, the pivoting pivot shift was grade 2. So we decided, we talked with the patient party, we talked with the parents, and we decided to do surgical reconstruction of the ACL. So this is, we obtained MRI, and what we found was there was complex tear of the lateral meniscus along with the absent ACL. And from this coronal film, we found out that the physes were not fused. And to evaluate the maturity of the particular patient, we obtained the plain X-ray of the hand, and it is said that if the distal physis is if the physis of distal phalanx is fused, we can consider the patient as pubescent. In this particular case, the physis was not fused, so we considered this patient as prepubescent. So we decided to do all epiphyseal technique, and this was technique what we did. This is the our preferred technique, and in this technique we made the epiphyseal tunnel in the femoral side, then if all epiphyseal technique in the tibial side, then we pass the graft, the thread from the femoral side to tibial side, then we shuttle the graft first from the femoral to one of the tunnel of the tibia, then another tunnel back to the femoral side, and we fixed femoral side with the screw. So this is our setup. This is the surgical video. This is the setup. And we need the difference is we need the Siam. This is intraoperative picture where we can see the ACL is gone. We prepared the femoral tunnel, the site for femoral tunnel, and then we did the outside in drilling, with the round ACL drill guide. we confirm the all epiphyseal positioning of that particular base pin. Then we over drill that with 7 reamer. And now we drill the tibial side with the ACL jig, the tip aimer, and dilated both of them with the endoscopic reamer. Thus, we had 2 tibial tunnels and 1 femoral tunnel. So now we routed our graft from femur side to tibia, then back to the femoral tunnel from the another tunnel that is made in the tibia. So this was how we did, and both the limbs of the graft were put into traction and fixed with the interference screw in the femoral side by outside intake. This is the breeze what we obtained in the tibial side. So this is immediate post-operative picture. There was the anterior laxity was gone, pivoting was gone, anterior draw test was negative, and this is the picture. So this is 6 months for that particular patient, and we can see good anterior stability of that patient. The pivot shift is gone. Patient is back to his normal activity. He's attending his school. He is doing his works. And this is the 6 months follow-up X-ray where we can see the tunnel in the femoral and tibial side, the 2 tunnels in the tibial side and 1 tunnel in the femoral side. So as we do the cases of pediatric ACL reconstruction, there are many things to consider, like growth trimming should be calculated and surgery should be done according to the physis status. Soft tissue graft should be always preferred, avoid the bone blocks because they will lead to physeal bar formation. If transphyseal tunnel has to be made, always make the vertical tunnels because oblique tunnels will increase the physeal violation more. We have to avoid implants at the physis. So if we use the transphyseal technique in the tibial side, we have to measure the physeal position, and thus the size of the interference screw has to be determined accordingly. So graft ligamentization do occur in pediatric population as well. And as the graft ligamentize because of longitudinal growth of this pediatric population, they become more vertical due to longitudinal growth. And while they grow, graft also grows, but what has been found in literature is the length only increases, width does not. That's why these pediatric ACL reconstruction has more chance of re-rupture in future, and it has been shown up to 3 to 5 times more chance of re-rupture in future than in the adult counterpart. So take home message is ACL tear is increasing in pediatric population because of active participation in sporting activities. Surgical management gives better result, and delay in surgery will lead to secondary injuries. Surgical technique has to be tailored according to the various parameters like I have just mentioned, and these children are not to be considered as the small adults. So please follow the safety norms of COVID-19 for and stay safe. Thank you so much.
Thank you, Vivek, for the wonderful presentation. So with this, now we have come to our last talk of the day. I would like to request Amit sir to present today's ICL talk on the phases of shoulder dislocation, what we learned from this. Hazard.
This is Nagmani.
Yes, yes.
I wanted to ask a couple of questions to Vivek just to
Okay.
clarify
Okay.
regarding technique. Vivek, could you highlight on your post-operative rehabilitation protocol after ACL reconstruction? Is it same as adults or do you modify? And then the second thing, what is your take on ACL repairs along with augmentation in pediatric ACL?
Thank you so much for the question, Nagmani. So, regarding our post-operative protocol, that is, we did no different. That is the same accelerated ACL rehab protocol. We did no difference than the adult population. So, and regarding your second question, what was your second question? Please come again.
What is your take on repairs if the remnants are available along with internal bracing like Beer procedure and all?
Okay. So as far still now we have not repaired any of the pediatric ACL tears. So most of our pediatric ACL reconstruction cases had this particular case had no particular good remnant, so we didn't try to repair. So I think repair can be done, but reconstruction is better one.
Thank you, Vivek.
Thank you, Day.
Thank you very much, everyone. Am I audible and my slide is visible?
It's 11 hours.
Yes, sir. It's audible and you are visible.
Thank you very much, all the presenters. Those were excellent learning opportunity for all of us. And today I'm going to talk on a little different aspect of shoulder dislocation. So shoulder dislocation is very common in our practice, and we all come across this kind of dislocation. A recently done cap gap analysis by our team, they show that whenever we get a dislocation, we directly jump into reduction. And you won't be surprised by knowing that these reductions can be performed or are being performed in injury place and the medical facilities. So in injury place, it is not the doctors, but the patient himself. In most of the time, the shoulder was reduced by the patient himself, family members if it occurs at home, friends and bystander if it occurs in the road. So injury place reduction rate is very, very high. As far as the medical facility is concerned, so when, what, where the patient present, and based upon that, many people reduce these shoulder dislocation. And unfortunately, orthopedic surgeon is the last person who comes to reduce this shoulder. And when we talk about sports surgeon or a shoulder surgeon, they are nowhere in picture when we get a shoulder dislocation. So our cap gap analysis says that there is a tendency to consider reduction as a final treatment. So if you have reduced your shoulder, you have treated. Unfortunately, it is in contrast with the literature which says that treatment of a shoulder dislocation should start after the reduction. So reduction is not the ultimate. Your treatment should start after the reduction because the shoulder dislocation has various phases. This clear-cut dislocation will not show you the age of the patient. Either this is first time or recurrent dislocation, traumatic or atraumatic dislocation, ligamentous laxity, seizure, or so many things, which is not able to cover. So a simple looking X-ray may have very completely different face. So aim of my presentation would be to show some of unusual phases of shoulder dislocation and the lesson learned from these cases at our center. So this is my first case. I'll quickly go into this. This was a 58-year-old lady. And you know that she sustained a road traffic accident. She was a pylon rider and fell down, an injury on her left shoulder 25 years back. And throughout these 25 years, she was having some pain, clicking, and main problem was what she said in Nepali is सड्किने हुन्छ, मेरो shoulder सड्किन्छ, फर्किया जस्तो हुन्छ भन्छ. But she was never having a frank history of dislocation. And during these 25 years, she has visited so many centers, and she had already done more than 30 X-rays and 4 MRIs, and some of these X-rays were done by me as well when I saw her about 6 years ago. So these were the X-ray, which was perfectly, probably there was nothing, to be noticed in these X-ray which has been done. As far as the MRI is concerned, you could see that MRI showed ACJ arthritis, osteoarthritis of the shoulder, which my markers are pointing out. And then with this diagnosis, she has received 6 dipomedrol shots on her shoulder and multiple years of physiotherapy. That is what she was going through. This is another MRI which says that there is a osteoarthritis, biceps tendinitis, and again for this she received 2 DMI shots on her bicipital groove, and again physiotherapy, but she was not relieved. So when she came to me, I have examined her long ago and also managed conservatively. When she came to me again about 4 years back, I routinely and thoroughly examined and found out that apart from rotator cuff osteoarthritis symptoms, she had apprehension test as well. And this enlightened me. And then when I went to review her X-ray, if you see these axial cuts, you could see that in this cut, you could see there is a irregularity in the anterior part of the glenoid, which indicating that there is a bone loss in the glenoid. Again, these were the old MRI in which we have missed certain diagnosis, which clearly shows that there is a deep Hill-Sachs lesion which was missed. And retrospectively looking at the glenoid, you could see that there was a bone loss as well. So since there was a bone loss in both the sites, we decided to do a CT scan. And now we were enlightened by the CT scan that there was a severe bone loss on her left side, and there was a deep Hill-Sachs lesion on her left side, which was diagnosed by this 3D CT scan. So we offered this lady a Latarze procedure for the glenoid bone deficit. And along with this Latarze procedure, since she had kind of shoulder subluxation, not frank dislocation for more than 250 times, we decided to offer her a Hill-Sachs bone grafting as well, because it was really broad and deep as well. So we did a Latarze procedure at the same setting. We did a Hill-Sachs bone grafting. And this is intra-op pictures of screws for Latarze procedure and the bone grafting of the Hill-Sachs. It took little longer time to recover for her, and then after 2 years, she disappeared, and she recently presented to us with the 4 years of follow-up when we did the X-ray and CT scan of the same lady, which shows that the coracoid process has nicely healed into the glenoid, though it looks higher up, but nicely healed. The bone graft into the Hill-Sachs lesion is also nicely healed. And if you see her range of motion, she has almost full range of motion. There is a minimal pain which is attributed to the osteoarthritis and the AC joint arthritis maybe. There was a little bit of clicking sound which is acceptable for this patient. And more importantly, the problem that she was having, Sardkine and Mordkine problem of her shoulder, was completely resolved, and the patient was very happy. The literature also says that recurrent subluxation are commonly misdiagnosed as various pathology of the shoulder. So the lesson that we learned from this particular case was not all dislocation presents as a frank dislocation. When we deal with shoulder pathology, examination for instability must be included. So whenever we examine the shoulder, test for instability, especially the apprehension test, has to be done. Another interesting case, a very young guy, 33-year-old gentleman, 5 days history of motorcycle accident, had dislocated his shoulder, reduction performed at local center. So he went to his local hospital, where you could see that very nicely reduced shoulder, in which he has done both pre and post-operative X-ray. But a very meticulous surgeon saw that who saw that who examined the patient after the reduction, and he said to the patient that your joint is very unstable, so you might need further examination. And because of this advice by one of our colleague to the patient came to us. So the patient came to us. When the patient came to us on the 6th day of his injury, he came with the shoulder immobilizer, and we saw that there is a massive bruise on the anterior, lateral, as well as in the posterior part of his upper arm. So these bruises are not very common with the normal dislocation. So because of these bruises, we thought that he must be having certain hidden fracture which is not visible in X-ray. So we did a CT scan. The CT scan showed very interesting two facts. There was no other fracture, but there was small fragment which has been, on the posterior aspect of the shoulder joint. And then more importantly, the non-concentric reduction of the shoulder was visible. So the shoulder was non-concentrically reduced, which is more visible in his 3D CT scan. You could see that the bony fragment, which is avulsed from the supraspinatus, is around at the level of the glenoid, and then there was non-concentric. So we did a MRI for this patient, and to our very much utter surprise, we saw that the whole subscap, if you could see that the subscap is all entrapped. Let me show you with this arrow that this is subscap which has been entrapped into the joint. So between the humeral head and the glenoid, this subscap is entrapped. It's not only the subscap, you could see that the infraspinatus is also torn. And let me show you another sagittal film which says that the rotator cuff is also torn. You could see that humeral head directly underneath the deltoid, and somewhere the supraspinatus is retracted right up to the level of the glenoid. So Pacte grade 3 retraction of the rotator cuff, traumatic. So we did an examination under anesthesia before surgery. You could see the bruises all up to the anterior chest wall. And then he has exaggerated rotation. So what we did, we decided to do an open repair of his rotator cuff through a deltopectoral approach. When we retracted the deltoid and the pectoralis, we could see the humeral head, bare humeral head right underneath the deltoid. And then it took us quite a long time to retrieve the subscapularis muscle, which has been interposed between the glenoid and the humeral head. This is after retrieval. When we applied a suture, we could retrieve. Then we did open double row repair of the both subscap, supraspinatus, and the infraspinatus. So this was done by open technique, but still was a double row repair. So this was the lateral row anchor which has been applied, and you could see that the very nicely repaired rotator cuff all around. So so this is his immediate post-op X-ray, and if you compare the pre-op and the post-op CT scan, although we were not able to get this small fragment, but the reduction was very much concentric in this particular patient. We could get this fragment all the way back to the uh, greater tubercle. So this is 4-week follow-up. We immediately started, since the patient was having double row repair, very robust repair. We started passive and active range of motion immediately, and this is what he was having at 4-week follow-up. And this is very recently he sent me at 6 weeks follow-up from home, since because of COVID status he couldn't come. And then you could see that his all rotator cuffs are firing and functioning, and hopefully in due course of time he'll recover completely. Literature also said that in traumatic dislocation of her shoulder, rotator cuff examination is very, very essential component, especially in patient older than 40 years. So whenever we have a shoulder dislocation, after dislocation, we must examine the status of the rotator cuff, because rotator cuff injury after the dislocation is very commonly missed. So the lesson learned from this case was examination after reduction is very important. Active initiation of abduction is very essential and should be performed after reduction. If there is a doubt, further investigation with the MRI is very, very essential. The third case is 31-year, again very young guy, 1 week history of trauma. He had a dislocation which has been reduced by the bystander at the time of accident. He visited orthopedic surgeon who did an X-ray, and there was a minimal small fracture of the greater tubercle, put on slab and sent back home. But he was unable to abduct the shoulder, and he was having pain, for which he came to us. And this is the X-ray in which you could see that there was a little bit of depressed GT fracture, but also on the lateral side, you could see that there is a small flake of lesser tubercle. So suspecting a bigger injury, we did a CT scan for this patient. To our fortunate, this small fracture, there was not much of displacement of these greater tubercle fracture. But if you go to another X-ray, CT, 3D CT, that is the on-first view of the bilateral glenoid, we found that there is a fracture of the glenoid which is displaced by more than 6 millimeter, which is not acceptable for this particular patient. So this was incidental finding, but he had a big chunk and then it is displaced by more than 6 millimeters. So we decided for arthroscopic fixation. You could see that there is a depression fracture. The GT is undisplaced, and the rotator cuff of this particular patient was intact. In the glenoid side, you could see that that is a fragment which has been displaced. So we used various arthroscopic instruments to reduce that. And then once it is reduced, we made a 5 o'clock portal. Through 5 o'clock portal, we put a cannula. So this is making of the 5 o'clock portal. A cannula has been placed in the 5 o'clock portal, and through this cannula, we passed a guide wire to provisionally stabilize the fragment. We checked the stability, and through this guide wire, we drilled the fragment and fixed this fragment with a partially threaded cancellous screw that we commonly use for Latarjet procedure. So this is partially threaded cancellous screw in the process of insertion. So this is completely is being done by arthroscopically and minimal invasive technique. And you could see that this is very nicely reduced. This is immediate post-op X-ray. And then in 12 weeks follow-up, the patient had full range of motion with his shoulder, and the patient was again very happy. So this is another paper which indicated that GT fracture indicates severe injury, and most of the time they are associated with glenoid fracture, especially the rim fracture. So detailed examination is advised if there is a GT fracture. So the lesson that we learned from this particular case was GT fracture indicates severe injury of the shoulder. The changing understanding of the GT fracture management warrants a detailed investigation with the CT scan. So if we see a GT fracture, which is usually with the dislocation, we have to be very, very careful of examining and investigating that patient. So this is my final case. I'll just quickly run through. This is again a very young gentleman, 38-year-old gentleman, sustained road traffic accident, and he was unable to move his shoulder. With that, he presented to a local hospital, and then in local hospital, this X-ray was done, which with this X-ray, he was diagnosed as a type 1 fracture, part 1 fracture, and the patient was put on U slab. And after 6 weeks, the U slab is removed, and this was his X-ray. You could see that the fracture was almost healing. U slab was removed, and the patient was advised for physiotherapy. But unfortunately, patient did not improve. He was saying that his external rotation was not very good. So patient went to the same hospital after 10 weeks in which this X-ray was done. And in this X-ray, it was very, very clear that this patient had a dislocation. If you see this, his previous X-ray, so from previous X-ray itself, if you retrospectively see that the patient was having posterior dislocation, which was missed as usual by one of us. Then the patient underwent the routine CT scan. And in this CT scan, you could see that this was a posteriorly locked dislocation. There is a big Hill-Sachs lesion, and there is a fracture of the lesser tubercle as well. But the lesser tubercle was already healing because it was 12 weeks by the time he had to undergo surgery. So this is a pre-operative, clinical picture in which you could see that reasonable good movement on his left shoulder, reasonable good movement. We advised him that if you are satisfied with the range of motion, we can manage you conservatively, but he was not satisfied. He wanted to put his hand on his head. So we decided to give him a surgery. So this patient underwent a modified McLaughlin's procedure in which we take out the small lesser tubercle. We osteotomize the lesser tubercle and fix this lesser tubercle to fill up the reverse Hill-Sachs lesion. In this case, it is anteriorly lying Hill-Sachs lesion, which is known as a reverse McLaughlin procedure. So this is intraoperative picture of that same patient. You could see that empty glenoid, the head is gone right back on that side. So it took us quite long time to gently reduce this. On top of that, the patient was having a recently healed fracture. So we were very cautious and gentle. And then you can see this after the reduction of the shoulder, you could see that the big Hill-Sachs lesion on the anterior aspect of the head. So this required fixation. There is a small fragment of the lesser tubercle which has been fixed into this place. So this is after the surgery, immediately after the surgery, where you could see that the lesser tubercle has been fixed. There has been Herbert screw, which has been used as an anchor in this particular case. So this is 2 weeks follow-up in that patient. Since the fixation was good and we used 2 screws for fixation of the lesser tubercle, we started immediate range of motion. This is after 6 weeks. Very recently, patient sent this X-ray to us. He said that he is improving, and he was very happy to say that he could comb his hair by his left hand. So this is just 7-week follow-up of this particular patient, and we are expecting much better result after some time. This is his CT scan, which says that the fracture is in the process of healing. I'll not go into detail, but the literature also said that posterior dislocation is missed in 60-70% of initial examination. So it is associated, if it is associated with fracture, these dislocations are very often missed. So the lesson learned from this patient is whenever there is a fracture around the joint, associated dislocation has to be suspected and adequately investigated. So to conclude these various phases of dislocation, I would say that shoulder dislocation may present in various phases. Subluxation has to be ruled out in all shoulder pain of the patient who are coming to us. A comprehensive examination of shoulder dislocation cannot be complete without post-reduction examination. And this is one point I would like to request to note to all my colleagues, that after reduction, a thorough examination has to be done for stability, for rotator cuff, and for other injuries that may be associated with. GT fracture in shoulder dislocation is feature of high velocity injury. So adequate clinical and radiological examination is needed. We should not neglect even an undisplaced GT fracture. A thorough examination and probably a CT scan is the gold standard at this moment. If there is a fracture around the shoulder, a dislocation must be ruled out. So even if there is a small fracture around the shoulder, please let us make sure that the dislocation is ruled out. With this, I'd like to thank Nepal Orthopedic Association for the opportunity and would request all my friends to stay home, stay safe, and pray for the frontliners, our colleagues who are working in this COVID situation. Thank you very much.
Thank you, sir, for the wonderful presentation. So we have some few questions. What is the safe time to do this apprehension test to do after a treated shoulder dislocation?
So apprehension test can be done by a patient who is under anesthesia. That means you try to dislocate the shoulder immediately after reduction. That will tell you how stable your shoulder is after dislocation. So for apprehension test, you know that you need 90-degree abduction and 90-degree of external rotation. So to do this test, whenever the patient is having this range of motion, that is 90-degree of abduction and 90-degree of external rotation, you can do the apprehension test. I think I have answered his question.
So is there any particular extra view to see posterior dislocation?
Absolutely. I think I did not include that thing because, axillary lateral view is commonly recommended by us for the diagnosis of both anterior and posterior dislocation. It still remains the gold standard. But imagine that if someone has dislocated a shoulder, abduction of 45-degree of shoulder is not possible, which is essential for axillary lateral view. There is another view which is very, very important, and if it is not possible to abduct shoulder and not possible to gain an axillary view, that is called scapular Y view. That is also known as en-face view of the glenoid. So we must have a scapular Y view. So any patient with shoulder dislocation, both views, AP and a lateral view, either axillary lateral or scapular Y view, must be done before sending the patient for the treatment.
So one more last question. How frequently do you get shoulder dislocation associated with the nerve injuries?
That's quite, axillary nerve injury is said to be very commonly associated with the shoulder dislocation, which is in around 10 to 15% of the cases. So we've been reviewing our 550 cases of shoulder surgery, and then we found that this is not very high in our case. Also, it depends upon so many things, but absolutely, and the very good question that whenever we do examine a shoulder dislocation, examination of the axillary nerve or intactness of the axillary nerve must be recorded. And then as far as the other nerve injury, so say brachial plexus injury can occur. This depends upon the severity of injury, but it's extremely rare. But neurological examination after reduction or before reduction of a shoulder dislocation is very, very good point. And I'd like to thank you for raising this point.
Thank you, sir. So thank you for the enlightening ICL on the shoulder dislocation. So with this, we have come to an end of today's Nepal Orthopedic Association bi-monthly CME webinar. And I would like to request Nepal Orthopedic Association President, Dr. Ravindra Lal Pradhan, sir, to give closing remarks.
So good morning, everyone. And thank you very much for attending the first NOA bi-monthly meeting and making it such a great success. And thank you very much for all the speakers. Like Dr. Silas said in the beginning, we had quite a few interesting cases right from hand until the last ICL, which was fantastic. Thank you, Amit, for an enlightening presentation. It was really wonderful.
Welcome, sir.
And a lot of things need to be gathered from this meeting, in a sense that this will be not only useful for our residents, but I think the surgeons who are practicing throughout Nepal and surgeons who have been slightly towards more focused on an subspecialty basis needs to realize that people who are doing subspecialty treatment have a slight advantage over people who are doing general orthopedics. So if you have any doubt, I think it would be better if we can refer it to our colleague who has been doing, subspecialty practice, let's say a major part of their subspecialty practice. I think the last presentation by Amit shows that we need to not only focus on general orthopedics, but I think, to focus more on subspecialty would enhance our knowledge and our skill better. And like everybody said, stay safe. And I think with this pandemic raging, we think we will still be continuing our bi-monthly activities in the digital medium, I think. We'd all like to meet and have chats, but I think it may not be possible in the near future. But I think even the digital platform has been excellent. I mean, today the presentations were very good, and the take-home message for the juniors as well as the seniors has been right up to the mark. Thank you very much, and hopefully we'll see you somewhere soon. Back to Dr. Silas for the final remarks.
Thank you very much for everyone to come in here. I think our next bi-monthly meeting will be in July, and I will circulate it as, and it's going to be Birendra Hospital. We will also be having a subspecialty presentation next month. I will circulate that accordingly. That should be all right. Thank you very much for everyone attending. Have a great day. Have a great Saturday. Thank you.
Thank you. Thank you, sir.
Bye-bye. Bye-bye. And thanks a lot, BNB, for everything. Thank you. Bye-bye.
Thank you. Thank you, everyone, for your presence. Stay safe and take care.
Take care. Bye-bye.